Welcome to Little Steps, Big Gains in episode 1 of our series on the treatment of upper limb ataxia, clinical characteristics. Throughout this episode, we're going to review that role of the cerebellum and then common clinical characteristics that we see with cerebellar ataxia. However, if you haven't already, check out episodes 1 and 2 in the evaluation of upper limb ataxia. You can find links to those in the description below because in those episodes, we dive a little bit deeper into these subject matters that will set up the foundation for our treatment interventions. Ataxia, that is Latin for loss of order, and is clinically characterized by a lack of coordination and tremor, an action tremor. Now, it can be acquired from something like multiple sclerosis, cerebellar stroke, brainstem tumor are a few examples. But it then in and of itself can be with a genetic origin, a hereditary disorder, like a spinocerebellar ataxia. So whether the cerebellar ataxia is from something acquired or hereditary, it has a commonality, and that is a part of the brain called the cerebellum. It's in the back. It's Latin for little brain. It plays a huge role in our balance, equilibrium, and motor planning, executing our movements. When it comes to balance, we have 3 sensory systems that talk to the brain and tell it where we are in space so that it can maintain our balance. Those 3 include the visual system, the somatosensory system. That would be a combination of proprioception in the limbs and then touch, pressure, vibration, tactile input. You put that together for the somatosensory system. That 3rd system is in the inner ear, diverts from the auditory system, and it's that vestibular system. And it tells the brain where we are relative to gravity, our head position. We're looking to the left, bending down. All of those put together. I have a video that breaks that down in the description below if you want to learn more on the role of the sensory systems in maintaining our balance. But when all of that information comes to the brain, it is the cerebellum that plays a huge role in organizing all of it. So if we have damage or degeneration there, that is going to play a huge role in our balance and equilibrium. When it comes time for motor planning, I like to call the cerebellum our GPS because it has 3 different roles. So first off, when we're reaching into a cabinet or stepping, the limb is going to tell the brain where it is. The brain needs to decide, is that where it's supposed to be? Because if it's off course, the cerebellum kicks in to correct the errors. But then it does 2 other things. First off, it remembers the errors to prevent them from reoccurring in the future. And then, like a GPS, it predicts the movement ahead of time. So if I'm here, it's going to tell the brain, you need to go here next. If we struggle with that prediction, larger movements are going to be broken down into smaller segments that might be jerkier along the way. So that GPS, it goes ahead and it corrects the errors, remembers the errors, and then predicts our movements ahead of time. The cerebellum can be divided into 3 anatomical subdivisions, but also 3 functional subdivisions. We are going to focus on the functional subdivisions because that plays a role manifested in the clinical characteristics that we are targeting. So here's a picture of those 3 functional subdivisions. Now, if you look at the picture on the right in the diagram, right between those dotted lines, we have the middle vermis called the spinocerebellum. It's responsible for executing our movements, motor execution. On the sides, each side of those dotted lines, laterally, we have the cerebrocerebellum. This part of the cerebellum is responsible for timing our movements, motor timing. And then on the bottom, there's that little orange strip, that horizontal strip. That is the vestibulocerebellum, and it plays a huge role in equilibrium, movement of the eyes, head, and neck. Now, what are some of the clinical characteristics that we see from damage or degeneration to those functional subdivisions? Well, we're going to break down a few here. First, we have something called dysmetria. It's basically when you reach or step, it's an under or overshooting of a target. Second, we have a tremor. We talked about this in episode 3 of the evaluation of upper limb ataxia. When it comes time for tremors with cerebellar ataxia, they're action tremors with movement. This could be an essential tremor, which is more of a postural tremor, or with movement, an intention tremor, where the amplitude of the tremor actually gets bigger the closer we get to the target. Hypotonia, the cerebellum plays a huge role in modulating what's called gamma motor neurons. And if you're wondering why that's important, gamma motor neurons play a role in the actual tension of our muscles. If we don't have tension there, our brain is going to lack a lot of the proprioception of where that joint is. And that plays a huge role in our motor planning, right? Next, we have ocular motor impairments. The cerebellum is actually a network hub for the movements of the eyes, and that plays a huge role. We're going to break that down later on. The role of the eyes in jumping back and forth, in tracking items, in converging together, how those eye movements play a role in executing our movements and balance. We'll break that down a little bit more. Ataxic dysarthria, that's basically slurred speech. That might be caused from difficulty coordinating the muscles around the mouth, but also the respiratory system. People tend to run out of breath sometimes. Titubation, that's the medical term for a truncal ataxia, oscillations, dyssynergia, grasping deficits, and diadochokinesia. Big words. We'll break those down briefly. Diadochokinesia, a really big term, but it's basically impairment in rapid alternating movements. Ellie's going to show us an example of this, where she's going to show us rapid pronation supination, screwing in a light bulb, table tapping, finger tapping. Let's watch and talk about that. Here you can see with diadochokinesia, we see a dissociation in the time and the force of the contractions. We have a delay in the initiation of one movement and then quickly stopping at turning points. This is so difficult because rapid speed of these movements deprives the brain from a lot of incoming information so that it can regulate the timing and force of those muscle contractions. Finally, grasping. When it comes time for grasping, we can actually break it down into 3 different components. First is the hand transport, that movement of the hand to the object. Now, once we get to the object, there is the grasp type selection. What kind of grasp do we need to use for that specific object? Once we select the grasp type selection, there's the grasp force selection. What is the calibration that is required, the force to lift that specific object? Now, when it comes time for cerebellar ataxia, when it comes to the hand transport, often there is a delay in the initiation of the movement. Then as we reach, we may see an intention tremor, where we may over or undershoot for that object when reaching for it. Remember, that's dysmetria. There would then be a prolonged time it takes for the correct type of grasp selection type, and then impairments in the grasp force selection, the calibration that is required for the force to lift that specific object. Also, interestingly, we have something called reactive grasping control and predictive grasping control. Let's watch Ellie real quick. Reactive grasping control would be if I dropped an object into her hand and she had to catch it like a tennis ball. That would be her reaction, the reactive grasping control. Second is predictive grasping control. If she were to drop the tennis ball from her hand into the other, predictive grasping control. What do you think is more difficult in cerebellar ataxia? Reactive, where they have to kind of catch the ball if I drop it, or predictive, where they catch their own tennis ball? Well, let's take a look and see. As you can see, it is predictive grasping control that is more impaired with cerebellar ataxia. And that is because that cerebellum plays a huge role in predicting the consequence of our movements. Now, we're going to end today by listening to the ataxia community, because that is where we can really learn about functional applications of all of this information. I received a ton of responses from support groups when I asked, what are some difficult upper extremity tasks? And here are a few that we can learn from. Picking up a wine glass, writing on a whiteboard, pouring water or milk, carrying a glass without spilling, inserting my credit card into a machine, cutting meat, picking up things without knocking everything over around it, or say I'm trying to pick up my toothbrush from a crowded countertop, or move chess pieces that's surrounded by other pieces. interacting with those touch screen kiosks they have in airports, narrowing in on an object and closing my hands with equal pressure between my thumb and fingers to pick up an object. It's more when I'm trying to pick up things. I think I have it securely, but I don't actually. Grabbing things too hard or too weak and dropping it straight away. Or if I'm holding something for a while, my sensation and intention to hold it relaxes and I drop it out of nowhere. Coordination between the brain and hands. I think I'm cueing my fingers to release while hovering over the waste bin, but my fingers don't release until the hand is no longer over the bin. The grip, the push, the pull. I have a difficult time managing my feel. Sometimes because the pressure is uneven, objects flip right outside my grasp. Sometimes when I'm trying to pick up things, but most often half an instant after picking up, as my fingers try to cope with the grip commands my brain is sending. And finally, I call it my finest comedy sketch so far. Unpacking, I remind myself to slow down with the cream buns. At which point I jerk my arm, knocking buns to the edge of the surface, overreact, knocking them off, go to stop it with my knee, slightly squashing them. They fall to the floor. I pick them up with a vice-like grip, squashing them totally. You couldn't make it up. And that was episode 1 of our series here on the treatment for upper limb ataxia. We reviewed the role of the cerebellum and common clinical characteristics seen with cerebellar ataxia. If you want to dive into these subject matters a little bit deeper, check out those links in the description below. And come back for our follow-up episodes on the treatment of upper limb ataxia. If you found this particular video helpful, educational, please press that like button below, subscribe to my channel, and even better, share with others. My link to Patreon is in that description below. And then check out other free educational videos and free home exercise programs here on Little Steps, Big Gains.